Hi, and welcome back to our second video of the lecture having to do with chronic illness and disease. And I broke this up because there is so much information out there. I wanted to give you a chance to kind of catch up, but also not lure you to sleep with this. So we're going to pick right up here in diabetes. And this is kind of one of the hotter topics that I wanted to kind of push on. Even though it's kind of lower on the causes of death, it's creeping up in its frequency of occurrence in the American society. Right now, we're looking at about 10% of the U.S. population who have an association to diabetes, and so I say it that way because there is two types of diabetes, and I really have to tell you that it's my own personal belief that we need to revisit this disease specifically, and probably consider a name change because the two are so radically different in the way they act. But type 1 diabetes and type 2 diabetes kind of share some things, and that typically has to do with blood glucose and insulin. But the way that those are reacting considerably different. So number 7, cause of death. Here we go. It typically comes down to an inadequate secretion or an inadequate utilization of the hormone insulin. And insulin is something that is produced by the pancreas. And so you're talking about an organ inside your belly, and when you consume food, it understands that that food has been brought into the digestive process, and what it does is in turn says, insulin, go take care of this food and put it in storage, or go ahead and get it kicked out there into to circulation. And so insulin goes out, and if it's kind of out there and we don't need it for immediate energy, then what happens is glucose or carbohydrates specifically are grabbed, they're taken to the liver, and they're stored there for energy later. And I'm going to kind of hit on that liver again because we've talked about that a couple times, but hyperglycemia, this is kind of the thing that we are concerned about, and that basically means high blood sugar. If you look at the term and you break it down from medical terminology, hyper is increased, glyce is the sugar, and emia meaning blood, so high sugar in the blood. And this eventually affects nerves. And so what we have to understand is that type 1 diabetes, it's really more of an autoimmune issue, meaning that the body destroys the insulin producing cells, and that happens early in life because it recognizes that as an invader, and that's an inappropriate thing. And so it's a very detrimental condition that occurs early in life because that affects what it is that you can do with the food that you're eating. Type 2 diabetes is very different in that insulin becomes basically deficient in its ability to manage that blood glucose. And kind of the example I want to give to you is if you were in a household where people yell a lot, and they yelled because they wanted to get your attention, then eventually there would come a point where you would no longer respond to the yelling because that was just part of your lifestyle. And that's a terrible lifestyle, and I'm sorry if that was you, but I'm just making this as a way for you to understand this here. But eventually insulin basically has to yell to get your body's attention, and then it needs more of it because it's going to increase the volume of the yelling. Well, the more insulin comes in and more insulin comes in, and eventually there's no more insulin that can come in because it just is not working, and so it's not moving those said carbohydrates or glucose into storage, and those are just staying in the blood system, and there comes hyperglycemia. And so that onset happens typically later in life in the fourth and fifth decade. And that's where things are pretty serious. And that's why type 2 is very different than type 1. And so I hope that that kind of gives you some clarity there. Type 1, insulin dependent diabetics, that means they're probably going to be the ones who are using a MDI or a multiple daily injection of insulin to help control their blood glucose. Where type 2, typically with the right types of exercise and diet, can control that. It's kind of key though that you pick up the right kind, and that's open for debate and right now, and we'll kind of see that later as we talk about diet. But type 2 is the one I'm kind of lean on here because this is the one that I think that I have the most position to help you in risk factors of. And so type 2, typically what we see with that patient is they had a poor diet, they didn't participate in exercise, if any at all, and they had an increasing body mass index. Now, that's kind of a crucial thing, and I'm going to talk about insulin resistance here in a minute, and we'll get back into that. But is it the chicken or the egg? Which one came first? And then they participated in some other just really poor behaviors. And typically that results back into that diet situation where their glucose was just not controlled. These were the people who ate a lot of processed foods, things that came from packages. Possibly they had a lot of white flour, white sugar, processed sugar, soda, different things like that, and even alcohol in their daily intake. So again, between 35 and 64 is where we see that common diagnosis occur. Their BMI, their body mass index, and we haven't talked body composition yet, but we will, is greater than 30, and that's typically at the obese stage. Physically, they're very inactive. They don't do anything more than what they have to do, so they get that sedentary lifestyle assignment to them. Their glucose, again, is terribly uncontrolled, and many times these people have a family history of type 2 diabetes, and so a lot of folks will say, well, that's a genetic, non-modifiable risk factor, and honestly, I would have to disagree wholeheartedly. Their family history probably has more to do with nurture, meaning that they grew up in a household where they were given lots of soda, possibly lots of processed foods, or taught to eat in a way that really kind of lent itself to this condition coming. And so that is something that you have to kind of look at in depth and kind of consider, but definitely a genetic contribution could have been played. Another thing is gestational diabetes could have happened, and that's for females who became diabetic and didn't control their glucose intake during gestation or pregnancy very well. And then also ethnic status. It's a foregone conclusion now that if you are Native American, your risk of diabetes, specifically type 2, is astronomically higher than a Caucasian. And there's a lot of thought as to why that is. But we know that there's some definite cultural differences there. Then there's this other thing called prediabetes, and I'm going to kind of get into that here in a minute. But if you remain pre-diabetic for a very long time, that means that you're not controlling your glucose intake. Then typically you fall into that next stage of type 2 diabetes. These next two terms are kind of the interesting terms, and I want to spend just a little bit more time on them. Insulin resistance means that your body basically doesn't use insulin the way it should. And earlier I cited which came first, the chicken or the egg. And I have to tell you that it's very difficult here because many times in our very recent medical history, we have kind of attributed that a person became insulin resistant because they were obese or overweight. Now we've kind of looked at it differently, and we were kind of looking at it and saying, well, maybe a person was insulin resistant and that led them to become overweight or obese. And I have to tell you that looking at a lot of recent information, I'm kind of trending that way myself, is saying something's causing a person to be insulin resistant, and then that leads down the road of overweight obesity. But, it could go either way. And we don't have um, evidence that says for sure one way or another, but it sure is looking like that it could go the reverse of the way we've typically thought it to be. And then there's this thing called insulin sensitivity. And that's basically your ability to understand with your body how to use that insulin in a better way. And so these are two contrasting terms here. Insulin resistance, meaning your body doesn't use insulin the right way. Insulin sensitivity, meaning that your body is using it really well and you're sensitive on how to deal with certain foods and activities to keep your insulin at bay. So we look now at some slides from the past. This slide over on the left, modifiable risk factors for CVD, that came up in the cardiovascular disease chapter. And I want to point out how diabetes and poorly controlled blood sugar had a big risk factor for CVD. And then I want to come over here to go back to module 2, which was stress. And I want to point out something that I did then. And I said that the digestive system, extra glucose from the liver is increased when we have stressful situations. So chronic stress basically sits down there and says, liver, release some glucose. That's just one of your 500 jobs to do. And it does this over and over and over and over and over when we're in chronic stress. Well, the problem is that if you remain in chronic stress and you release a lot of glucose from your liver, then you're going to have to use it. And if you don't use it, then it's going to sit there and it's going to cause hyperglycemia, a very low grade level of it, but it's still going to happen. And so what you want to do is you want to reduce that chronic stress to prevent that from happening. Just some other risk factors to kind of remember and think about that have some comorbidities tied to them that are very situational to diabetes. And so now we look at this thing right here. This is an Ultra 2 OneTouch blood glucometer. And what it does is it checks blood levels for blood glucose or blood sugar. And normally that should be less than 100 if you're fasted. And if it goes above that, then this is where we're kind of looking at people and saying, well, they may be pre-diabetic. And we want to look at this for a long time because just one time may not mean much. But if you looked at this and you found this to be true for, a month or 6 weeks or 8 weeks, then that would definitely give us some red flags to see our doctor. And then you look down and you see something else. And this is something that's very commonly spoke about now with diabetes, and that is hemoglobin A1C. Before I go on to the next slide, I want to kind of say that if you're consistently over that 125 mark in a fasting blood glucose, that's a very real risk, and that's indicative of diabetes. Now back to this hemoglobin A1C. If you watch TV, you've probably heard several commercials that had to do with A1C. If you've had a surgery recently, maybe they've been looking at A1C. But A1C is basically the part of hemoglobin which is a red blood cell oxygen transport system. That means that's where the oxygen is moved across in the blood. This is basically a level of how much sugar is attached to that part of the red blood cell. And they can measure that pretty easily with blood, but they look at it over months. And as long as you're running that 5.7% over several months, you're considered fine. They'll look at it and they'll say anything 5.7 to 6.4, that's definitely pre-diabetic. And anything over 6.5, man, you're at diabetes. So what are the two numbers we're looking at here? A 126 in your fasted blood glucose, a A1C over 6.5, then you look at that over a couple of months, you're probably going to get handed that type 2 diabetes diagnosis. I would also urge you to take a look at this article. It's very, very good because what it says is that we got to look at more things than just A1C when we're doing these type 2 diabetic diagnoses. Great article from Harvard Health. I highly recommend that you spend time looking at that. Now, I want to give you a few other chronic illnesses, and not necessarily diseases, but also just conditions that I feel like don't get a lot of looks, but really need them. They're not probably causing any deaths, but they're certainly attributing to some definite declines in quality of life. And so the first one, osteoporosis. And that is typically where the bones become more porotic, or they have more porosity in them, meaning they're not as dense or hard as they once were. And this has a big risk factor with postmenopausal women, because once a woman goes through menopause, they lose their ability to uptake calcium. And so that's a very dangerous thing, because calcium is very important for the porosity or the density of bones. And so when they do that, around the fourth or fifth decade, that's when osteoporosis can come in. And it has heavy attributes to things like compression fractures in the spine, but also stress fractures in the legs and the hips. And that can be very debilitating and change what you're able to do. Another thing here is lack of weight-bearing exercise right here. And I want you to understand that there is a very common occurrence that once a person typically leaves their 20s and sometimes their 30s, they may stop with a lot of weight-bearing exercise or even weight-bearing activities. They tend to move more to sitting, and relaxing, and they don't go to work. They go to sit in an office in a cubicle, and that's a very devastating thing, because if you don't have weight bearing those bones, you lose what's known as Wolff's Law. And Wolff's Law basically says that when a bone is stressed, it gets harder and grows. Well, without that stress, you have no adaptation, and the bone's just doing what it should do, and that is lowering its density because it's not asked to adapt. Another issue here is poor diet. What we know is that if a person eats a lot of processed foods, they drink alcohol, then they're going to lose the density of their bones. We'll talk more about these things as modules come with exercise and diet, but I think that that's really critical, that you're starting to see a connection of exercise, diet, and how important they are in offsetting long-term negative effects to our health. Here you go with race. We see a lot of females, specifically Asian females, will develop this as higher than other females will. Age is another thing. The higher the age, the more difficult it becomes. What we know is that if a woman waits till her fifth or sixth decade to start exercising, she may never see benefits from exercise towards osteoporosis. They may all just be a moot point at that stage. Also, family history, genetically predispositioned to have osteoporosis. And so how do we reduce our risk? Well, number one is we participate in weight-bearing exercise. What is that? That's walking, that's running. Here's what it's not. It's not swimming, because that's not a weight-bearing exercise. It's using strength training the right way. But also just staying physically active will make a huge difference. And that can be gardening, that can be house cleaning, that can be just walking your dog daily, but doing something to offset that high risk that is coming for all women, because you're going to go through menopause at some state. Improving your diet is an important thing, but then also, if you smoke, please stop as soon as you can. This is one thing that we know also attributes to bone remineralization. In fact, there's a lot of physicians out there who will not do an orthopedic surgery on a patient if they're smoking because they know that they're going to have a delay in healing. And so this is just all part and parcel to the idea that we're trying to sell you on, trying to improve that health from a global standpoint. Number two here is arthritis. And arthritis is our leading cause of disability in the U.S. We have tremendous amount of cases of arthritis in the U.S. And what we need to know is there are two types of arthritis. Number one is osteoarthritis, and this is typically the one when you hear the term arthritis, they're talking about osteoarthritis. Better term for this would be an osteoarthropathy, but definitely not an itis kind of condition. And I could get into a long talk about why, but osteoarthritis, number one thing that we typically hear about when we're hearing the word arthritis, and this is where the end of the bone basically wears down, and that's the movable part of the bone or the joint, and it doesn't wear down because you've exercise too much. It typically wears down because it wasn't asked to participate in exercise. It's also, I've got a word here, unilateral. That means one side. That means your right knee or your right hip, probably not your right and your left. And it happens because of age, but also excessive body weight. And so if you're overweight or obese, you run a higher risk of this because you were probably not active, but also because those bones are under stress and not really accommodated by strong muscle. Heredity is another issue. Being female makes you higher risk for osteoarthritis, and then also malalignment. And I would urge you to consider if you have extremely bow-legged or bow legs, then that's one of the key indicators that you have a malalignment. It's called genu varum. That's something that I would look for and also talk to my doctor about very soon, because you're probably predisposed to arthritis, especially knee arthritis, far faster than someone who doesn't. And some people have a very unilateral bow-legged where you can just see one side, and that's the person that's probably going to need a knee replacement and a hip replacement very, very soon in life. I also have in there metabolic syndrome. Again, that is anything that has to do with your metabolism, but diabetes specifically and non-alcoholic fatty liver disease, which we'll talk about in a moment, both kind of attribute to that. And then the biggest thing after that is trauma. If you have an old football injury, you can probably count on some arthritis coming from that later in life. I broke my collarbone a few years ago on a bicycle. I'm pretty much counting on some arthritis to come about because of that trauma. Rheumatoid arthritis is a very different situation. This is the true inflammatory brand of arthritis. It's actually chronic in its inflammatory state, and it typically affects joints across the body, right and left. So if your right hand has rheumatoid arthritis, your left hand has it. And you can see that through certain characteristics like ulnar drift and things like that. But smoking is a very big risk factor. Also, infectious triggers. The Epstein-Barr virus is a very well-known infectious trigger, but one other is being around parvo, which is typically associated with pets, is an infectious trigger. And then genetics obviously plays a role. I want to take just a minute to address this article at the bottom of your screen here from Runner's World. A few years ago, I had a friend, a colleague, asked me why I ran so much. I should be worried about my knees. He works in physical therapy too, and I was incredibly disappointed with the guy, But the reality is this. We have found and proven over and over and over that running does not increase the instance of arthritis in knees, but rather it decreases the instance of arthritis in the knees. It goes back to that whole Wolff's Law thing. If you use it, you will actually strengthen it. Specific adaptations to impose demands. You're going to hear that a lot as we move into the 8th module. But I want to tell you, read the article for yourself. Take a look at the resources and the citations that are there. Make a decision for yourself that is best for you. Non-alcoholic fatty liver disease, probably something you've never heard of before, something that is well on my radar, and I'm reading a lot about it. In fact, I have a book just over here on my table called Skinny Liver. That's just how impressed I am with what's coming out about this. Men's Health actually released an article a few months ago that said that because your liver has so many things to do, that it gets kind of pre-concerned with those things, and we can be so forgetful about something like the liver that we can go through the holidays and do these crazy binge eatings and cause massive amounts of damage to our liver. But hopefully we do some things after that to help it recover, and it does recover very well in time if left to do that. But non-alcoholic fatty liver disease, NAFLD, is a very common disorder, and it refers to a group of conditions where there's accumulation of excess fat on the liver of a person who drink little or no alcohol. And so when you think of alcohol, and you're going to see this in substance abuse in the next few modules, there's this thing called cirrhosis. Well, we're seeing cirrhosis occur from people who don't drink at all. And the most common form of NAFLD is a non-serious condition I'm sorry, it says non there, is a serious condition called fatty liver. And a quarter of Americans have it and probably don't know it. And so what we know is that eventually this could lead to a serious condition. So please make sure you omit this non right here. I apologize about that. But the risk factors are sugar and added sugar to things. If we're consuming sugar, even fruits to a certain extent can be too much sugar because of the spikes in our blood sugar and then the response from insulin. But added sugar, the things that we eat out of wrappers, all have added sugar. And I'm going to tell you that that's just the things that we're going to preach against you participating in long term or using regularly. Another thing is alcohol. Alcohol has its own sugar base, and that's where we see a lot of this coming in, but also just what alcohol does to the liver. Refined grains. This is going to get you because we are going to talk a lot about what refined grains are, specifically that of wheat, that of rice, and that of oats, which we typically see as probably a good quality, healthy food. But I'm going to throw out some different thoughts on that as we get into diet, but also nutrition. Fried foods, another awful thing for your liver because of the way your liver has to respond to metabolize those things. And so if you're eating a lot of fried foods, then what you have to expect is that liver is going to get cirrhosed eventually by dealing with a fatty outtake on itself. And then the last thing is a sedentary lifestyle. Again, what is that? Only doing things that you have to do actively through your day. So now we're going to get into this next thing. And again, this is not a disease. This is definitely a disorder here, right? And so forgive my misspelling here, but a disorder that when you look at the term insomnia, you have probably understood that that is something to do with sleep and not sleeping enough. And some of you are out there saying, this is me, I don't sleep enough. And I want to tell you something. It's become very apparent to me that we as a nation don't sleep enough. Sleep matters. 8 hours of quality sleep is incredibly important every night. And you have to guard that, but you have to also understand that we're not talking about 8 hours of crummy, crappy sleep. We're talking about 8 hours of really good sleep. And some associated problems with this are productivity loss, maybe at work, maybe during exercise, or maybe even just trying to do your job as a husband, wife, or parent. Drowsy driving. How many of you have driven drowsy before, and you know the risks that are involved with that, because one little subtle nod off can cause, well, you know, a head-on collision and death. So that's definitely an issue to deal with too. Anxiety, depression, all the way to Alzheimer's and dementia have been linked to sleep disorder take a look at this right here. I give you some links to click on. Here are your depression, anxiety, Alzheimer's, intelligence, dementia, and even cancer linked to sleep disorders. And so what I invite you to do is, if you're concerned and you want to see some of the research that is going on, I would encourage you to look at these. That might help motivate you to identify what it is that you need to do to get your sleep patterns in order. And sometimes a visit to your doctor is definitely the way to go. I personally want to say this: I'm not a fan of using a prescription medication really for anything, but especially if I can avoid it. I'm not saying that they're the devil. I'm just saying that if I can avoid it, I'm going to do it. And that comes from a long history of seeing both a parent and a sibling who had opioid dependencies. Now, with that being said, what I want you to do is I want you to understand what the risk is from either using a sleep medication or not having sleep, and making a decision that's best for you. I'm just saying, for me, I'm going to do everything I can to avoid a prescription, especially a pill. But the thing is, if that's what it took, I might be willing to talk on this one topic specifically. Closing thoughts here are this: education is always going to be key to holding control over most chronic disease, but the lock must be turned. That means you take your education and you apply it. You've seen me say poor diet. You've seen me say physical inactivity. You've seen me mention smoking and tobacco use, alcohol, increasing BMI, over and over and over. But unless you take that knowledge and you do something with it, you really need to plan on the fact that one of these conditions could come your way one day. I don't want that to happen. That's why I'm inviting you into this class to participate with this information. I hope that what you do is you look at the activity that's coming here you take this next quiz and you take it very seriously, and you use that to build up what it is that you need to make a good informed decision, but also act on it. Work the work that needs to be done to make sure that you're prepared for a risk prevention strategy. Hope this was good for you. Hope everything's working out. Let me know how things are going. Email or call me. See you soon.